Hi everyone, I am Dr. Windsor. Thank you for joining me for a discussion about hormones. In this lecture, there is a lot to learn. By the end, you should be able to define terms and abbreviations related to hormones in the endocrine system, as well as discuss the four main groups of hormonal action effects and the structure, function, and importance of various endocrine glands. You should also be able to explain the role of the surgical technologist regarding the handling of epinephrine. In addition, you should come away with the ability to identify adrenal cortex hormones and their purpose. You'll also gain a better understanding of the structure of the pancreas and how it functions. Lastly, you should be able to state medical and surgical uses for various hormones relating to the ovaries and the testes. Primarily, this is going to feel a lot like an anatomy and physiology review. As such, we should already have some familiarity with these concepts. So without further ado, I give you the endocrine system. You might be wondering why we need to talk about this through the lens of pharmacology in the surgical setting. This is because some hormones are used in surgery, and they may be administered from the sterile back table during the surgical procedure, so we need to know about that. Hormones and chemicals that are produced in the body and released by the endocrine glands into the circulatory system have specific effects on the body. We need to understand that. It's important that we don't get endocrine glands confused with exocrine glands, which are those that excrete substances into ducts or body cavities. Now, remember, endocrine glands secrete hormones into the circulatory system. Now, granted, most hormones are administered as replacement therapy and not commonly administered from the back table. While they are naturally occurring, there are several synthetic hormones that have also been developed, and we'll talk about some of those. These hormones, they have a wide variety of actions in the body, and as surg techs, like I said, it's our responsibility to know and understand why those medications are given before surgery, during surgery, or perhaps after surgery. As I mentioned, hormones do have a wide variety of actions. However, each hormone has a specific function at a specific location in our bodies. Collectively, they have been charged with their job is maintaining homeostasis in the body. They also play a really big role in reproduction, growth and development, and our metabolism. Hormones are basically chemicals that communicate with the nervous system, and that communication is going to bring about specific actions in the body. So let's take the example of parathyroid hormone, PTH, we abbreviate it as. So PTH is released from the parathyroid gland when the body senses that blood calcium levels are too low. Parathyroid hormone, PTH, is going to bind at the receptor sites of the osteoclasts. Remember, osteoclasts are those specialized bone cells that break down bone. So PTH is going to signal the osteoclasts to begin work breaking down bone, and consequently, calcium is going to be released into the surrounding tissues and then picked up by the circulatory system. And this will continue until that blood calcium level rises to a normal level. So you can see how parathyroid hormone, just like every other hormone, helps the body to maintain homeostasis in some special and unique and wonderful way. as I also mentioned, the endocrine system works with the nervous system to relay messages to the nervous system to maintain that homeostasis. And hormones don't work that fast, right? However, even though they are slower to work than the nervous system, their effects are typically going to last longer. It's also important to take note that hormonal effects are categorized into 4 main groups, and these are on the slide here for you. They include regulation of internal chemical balance and volume, responses to environmental changes including stress, trauma, and temperature changes, growth and development, and reproduction. Now, they can be further categorized or classified as steroid or non-steroid hormones. So tuck that away. We will come back to that in a little bit. So several glands are going to make up the endocrine system, and you can see them all there. There's a whole bunch. The hypothalamus, the pineal gland, the pituitary gland, thyroid and parathyroid, thymus, pancreas, adrenals, and the gonads. So we're going to discuss several of these during the next part of this lecture. First, I do want to talk about the difference between the steroid and the non-steroid hormones. Now, steroid hormones are derived from cholesterol, and they are further classified into 4 categories, and these include glucocorticoids, which is primarily cortisol. There's also mineralocorticoids, think aldosterone. There are estrogens, and then progesterones, and then lastly, androgens. And androgens are the male sex hormones, and here we're primarily talking about testosterone. Now, what about the non-steroid hormones? They're synthesized from amino acids. Remember, amino acids are the building blocks of proteins. Okay, so those derived from a single amino acid. One amino acid are the most simple, and they're referred to as amines. So some examples of amines would be epinephrine, norepinephrine, which are both secreted by the adrenal glands, thyroxine, and triiodothyronine. All right, now peptide hormones are going to be those that are made of short chains of amino acids, and some examples of those are antidiuretic hormone, or ADH, also oxytocin. Remember, oxytocin is the hormone that is responsible for causing uterine contractions. Protein hormones are going to be those that are composed of much longer chains of amino acids, and some examples of those are growth hormone, parathyroid hormone, insulin, and glucagon. Now, keep in mind that the vast majority of endocrine disorders are due to either hyposecretion from a gland or hypersecretion from the gland, right? So hyposecretion disorders are typically treated with hormone replacement therapy. If we have situations of hypersecretion, those may be treated with medication, or they might have to come and see us in the operating room to get the gland excised, or perhaps a portion of it excised. So first we're going to talk about the pituitary gland. Start at the top and we'll work our way down. So the pituitary gland is located in the brain. You can see it here on your slide. The pituitary gland is also referred to as the master gland. It pretty much controls all the hormone activities in our entire body. It's vital to reproduction and growth because it regulates the function of the kidneys and the thyroid gland. And as you can see in this bigger part of the image, the pituitary gland is connected to a part of the brain called the hypothalamus. You probably heard about it before. But there's this little stalk of the pituitary gland that connects it to the hypothalamus, and that's called the infundibulum because it's really fun. So it's called the infundibulum. The pituitary has two lobes. Like you can see here, it has an anterior lobe and a posterior lobe. The anterior lobe has a really awesome name. It's called adenohypophysis, and the posterior part is called the neurohypophysis. Now, the anterior portion is going to communicate with the hypothalamus and secrete stuff like human growth hormone, thyroid stimulating hormone, adenocorticotropic hormone, prolactin, dopamine, and gonadotropic hormones like luteinizing hormone and follicle stimulating hormone. Now, the neurohypophysis stores and releases oxytocin and vasopressin that is actually manufactured by the hypothalamus. So, oxytocin and vasopressin are manufactured in the hypothalamus, and then they're going to be stored in the neurohypophysis, the posterior portion of the pituitary, until it's time for it to be excreted. Remember, oxytocin, also called pitocin, is important to us as a surge tech because it stimulates the uterine contractions needed for labor. It's also used in C-sections when the natural contractions of the uterus aren't strong enough to kind of clamp down and stop that postpartum bleeding. So the anesthesia care provider may administer oxytocin or in some instances it might be injected directly into the uterus, and you might be the one drawing that up. We want to be extremely careful not to confuse pitocin with pitressin. Pitressin is a vasopressin, and it is used to stabilize fluid balance in patients with diabetes. So we want to make sure that we don't screw any medications up or get them mixed up, but very important distinguishing these two here. Moving on to talk about the thyroid. Now, the thyroid is the largest of the endocrine glands, and it consists of two lobes. You can see it here on your screen. It is connected by something called the isthmus. The isthmus. It is distal to the larynx and anterior to the trachea. The thyroid is responsible for setting the rate of the body's metabolism. Individuals that have hypothyroidism in childhood could have delayed mental and physical growth. As adults, they may feel like they don't have any energy. They may feel sleepy, tired, less alert. They may have less endurance, and they can also have a lower heart rate, bradycardia. Those experiencing hyperthyroidism, on the other hand, may appear restless and fidgety and nervous, and they can't sit still, and they're kind of always bouncing around. They may perspire. They may also experience tachycardia. The most common cause of hyperthyroidism is something called Graves' disease, and this is an autoimmune disorder where the body attacks the thyroid gland. Remember, autoimmune is the body attacks itself. So here the body attacks the thyroid gland, and that causes an overproduction of one of the hormones of the thyroid called thyroxine. So there are three thyroid hormones. There's T4, T3, and calcitonin. Now, T4 and T3 are regulated by the thyroid stimulating hormone that is produced by the anterior pituitary. Remember, that is called the adenohypophysis. So the adenohypophysis secretes thyroid stimulating hormone. It's going to stimulate the thyroid, right? It's going to stimulate it to release T3 and T4. And these two hormones play an essential role in normal growth and development. And like I said, they regulate metabolism of carbohydrates and fats and proteins in our bodies. They also require something very special for the production of the hormones, and that is iodine. Most, if not all, of the iodine that we take in from our food is transported to the thyroid gland, and this is actually active transport. Our body has to burn ATPs to get iodine to our thyroid, because remember, no energy is needed for molecules to move from areas of high concentration to low concentration. Here we have a situation where little bits of iodine are moving to an area where there's lots of it. So energy is required to do that, and then the iodine is used to manufacture T3 and T4 hormones. Interestingly, this is why we put iodine in our salt. Our salt is iodized, and that's because way back when they realized people were dying from not getting enough iodine in their diets, and so they started supplementing it in our salt. The third hormone I want to talk about with the thyroid is calcitonin. Calcitonin is going to help regulate calcium levels in the blood by doing the opposite of parathyroid hormone. So it is going to inhibit or stop the release of calcium from the bone. All right, this might be, the body has detected that calcium levels in the blood are getting a little bit too high, right? So calcitonin is going to be released to fix that. Either it's going to tell the parathyroid hormone to stop doing what it's doing, tell the parathyroid to stop secreting it. It's going to tell the kidneys to excrete it in the urine, right? Get rid of some calcium. Okay. And then thyroid hormones can be natural or synthetic, but they don't really have any direct surgical application. So they are used to support preoperative patient health, but in some instances, we may have visitors into our operating room that are needing to have a thyroidectomy. Next on our list is parathyroid glands. Now, if you were to pluck off someone's thyroid and turn it over and look at the back of it, that is where you're going to find the parathyroid glands living. And interestingly, not 100% of people have 4 parathyroid glands. 90% of people have 4 parathyroid glands. And like I said, they are usually found on the posterior side of the thyroid gland. And as I also mentioned previously, the parathyroid glands secrete parathyroid hormone. They made something easy for us. And again, PTH is going to stimulate the osteoclasts to start breaking down bone. And the process of the breaking down of bone is going to release calcium from the bone, which is then going to be taken up into the blood. It also works against the osteoblasts, right? Osteoblasts build bone. B for blast. Osteoblasts build bone. So parathyroid hormone is going to tell the osteoblast, stop building bone, right? We need calcium, okay? It's also going to tell the kidneys to reabsorb calcium, all right? Instead of kick it out, right? It's too low. We need to hold on to calcium, Okay, so kidneys are going to hang on to it. What happens if we have a low parathyroid hormone? This is going to cause hypoparathyroidism, which results in low blood calcium, which is called hypocalcemia. Hypocalcemia. And this can cause something called tetany, which is characterized by muscle spasms. So blood calcium is critically low. That's classified as tetany. Now, the opposite would be hyperparathyroidism, right? Which means we have too much calcium because the parathyroids are working overtime. And this can lead to brittle bone disease. We might also see muscle weakness or a depressed central nervous system. An example of a synthetic parathyroid hormone is called 4-TO or teriparatide. Because parathyroidism is treated medically, it's typically also not administered from the sterile back table. However, we may have individuals on our table that are having some of their parathyroid glands excised. Typically for a tumor, we can't excise them all. That's too dangerous. All right, next on our list of fun things to talk about is the adrenal glands. Now, the adrenal glands live on top of the kidneys. One of my students says they're the top hats of the kidneys. So the adrenal glands are the top hats of the kidneys, and there's one on each side. They are highly vascularized, and there's two parts to the adrenal gland. You can see them here on your screen. The middle part, the core, is called the medulla, the adrenal medulla, and the outer portion is called the adrenal cortex. Now, the adrenal medulla produces, stores, and secretes hormones epinephrine, which is also referred to as adrenaline, and norepinephrine, which we refer to as noradrenaline, and then a third hormone, dopamine. So the medulla produces, stores, and secretes epi, norepi, and dopamine. And together, all of these are referred to as catecholamines. And catecholamines are referred to as sympathomimetic. Sympathomimetic. What this means is that they work in tandem with the sympathetic nervous system. Remember, there's the sympathetic and the parasympathetic portions of the autonomic nervous system. And you might have heard of the sympathetic division called the fight or flight, right? So, have you ever had to stand up in front of the class and give a presentation? For most of us, this makes us feel really, really nervous, right? Our heart rates increase, our palms become sweaty, our breath quickens, we forget everything that we're going to say, right? This is what happens to our bodies with the adrenal glands release of epinephrine and norepinephrine. And as long as I've been teaching, 12 years, going on 13 years I've been teaching, I was called to speak at a high school, and they had some other business first before they were ready for me, so I was kind of waiting in the wings, and the next thing I know, I get this notification on my Apple Watch, and it says, "Are you exercising?" So I guess it had detected that my heart rate was a little bit elevated, and I was definitely experiencing a bit of fight or flight at that moment. So let's talk a little bit more about epinephrine. Remember, I said it's secreted from the medulla of the adrenal glands. It's also referred to as adrenaline, and it is frequently used in surgery. So as surg techs, we need to know what it is, how it works, how it's prepared, how we handle it, how it's administered. Notice that I have an example of lidocaine with epi here on the screen for you. And if a medication has epi, you are going to see red. Red indicates epinephrine. When we add epinephrine to a local anesthetic, it's going to prolong the anesthesia because in small amounts, it is considered a vasoconstrictor. It's going to cause the vessels to squish down, right? They're going to contract and they're going to get smaller, vasoconstrictor. So this is going to help keep that medication localized for a longer period of time, right? Because the blood vessels are constricting, not as much of the medication is going to get carried away in the circulatory system. Now, topically, epinephrine can be used as a hemostatic agent, and I worked with one plastic surgeon when we would do split thickness skin grafts. He wanted straight epi on the table. I would soak a sponge in it, and when he took the skin graft, I would put that on top of the donor site, right? The place where he took the split thickness skin graft from to help with hemostasis. When we are doing ears, right, concentrated epinephrine, a lot of time we use it in areas of capillary bleeding, but it is only topical, only ever topical in the ears. We never inject it. We also want to avoid injecting medication into the penis, toes, fingers, nose. So if you can remember that, it's kind of like a little rhyme. No epi, penis, toes, fingers, nose. And I've said it before, and I'm going to say it again. I'll probably keep saying it. We have to be really careful with this drug. Epinephrine that's used for ear surgery is a lot higher concentration. It is a ratio of 1 to 100,000. So it means there's 1 milligram of epi per milliliter. And we never, never, never want to load it into a syringe. We want to keep it in a shallow little dish where it can't be drawn up and accidentally injected into the patient. This could cause deadly tachycardia or hypertension for our patient. So we talked about the hormones that are secreted by the adrenal medulla. Let's talk about hormones that are secreted by the adrenal cortex. So the adrenal cortex, remember that's the outside part of the adrenal gland. And these hormones fall into 2 categories, and those are called glucocorticoids and mineral corticoids. Now, together, these hormones are known as steroids. Aldosterone is an example of a mineral corticoid, and it is essential for sodium conservation in the kidney, salivary glands, sweat glands, and colon. So this is going to work like an anti-diuretic, right? If we're conserving sodium, we're conserving water, right? So we're going to hold on to water with aldosterone. Now, of the 2 groups of hormones, glucocorticoids are most surgically significant because they reduce or inhibit the inflammatory response of the patient after such procedures as shoulder arthroscopies and actually a variety of orthopedic surgeries as well as organ transplants. They're also given to suppress hypersensitivity reactions, synovitis, arthritis, so on and so forth. They can be administered in a variety of ways, which include topically, orally, intravenously, intra-articularly, remember that's directly into the joint, or by inhalation. They can also be short-acting or long-lasting. And naturally occurring glucocorticoids include steroids such as cortisone, hydrocortisone, aldosterone, and deoxycorticosterone. Examples of synthetic ones are synthetic cortisone and hydrocortisone, prednisone, methylprednisolone, triminsulone, dexamethasone, and betamethasone. So did you notice that they all end in either SONE or LONE? This can be a way that you get a clue that these medications are indeed steroids. So the pancreas, it's divided into 3 anatomic areas, and those include the head, the body, and the tail. The pancreas is posterior to the stomach. It's kind of more on the left, situated on the left side of the, kind of middle left side of the abdomen. And the pancreas is pretty cool because it is both an exocrine gland and an endocrine gland. So exocrine-wise, it secretes digestive juices into the duodenum that helps us to break down our food. From an endocrine gland perspective, it secretes 2 hormones, insulin and glucagon. Remember, and these hormones are released into the circulatory system. So on the pancreas, there are these specialized areas that are called the islets of Langerhans. And these islets of Langerhans have 2 types of specialized cells, alpha ones and beta ones. And alpha cells secrete glucagon and the beta cells secrete insulin. So what do? Well, insulin and glucagon regulate the metabolism of glucose. Remember, glucose is the fuel. It's a simple sugar that our body uses during cellular respiration to make ATP. So let's say, here's the situation. The body recognizes that blood glucose is too low. Blood glucose is too low. Okay, so alpha cells wake up, secrete some glucagon. All right, glucagon is going to signal the liver to break down glycogen, which is how glucose is stored, back into glucose so that it can be taken up into the bloodstream and then be used by the cells to create energy. Now, let's say that the reverse is happening, that blood sugar is too high. Like, I just ate a gigantic Hershey's bar and I drank 2 liters of Coke, and my body's like, whoa, the pancreas is like, holy cow, there's too much sugar here. We need to release some insulin, right? So the beta cells are going to release insulin, and the insulin is going to tell the liver to take all that extra sugar and store it as glycogen. This process is called neoglucogenesis. Neoglucogenesis, we're making new molecules of glycogen, right? Now, here's the thing. There's only so much room in the liver for glycogen. So once the liver gets full of glycogen, glycogen is then stored in the muscles. When the muscles get their fill of glycogen, guess where the rest of it is stored? In our fluff, right? It is stored as adipose, and there is always extra room in the adipose for more glycogen. So that's kind of what the pancreas does in a nutshell. Now, neither of these really have a direct surgical use. They are used to treat, to medically treat or to regulate glucose. But remember, diabetes mellitus is the body's inability to regulate glucose. And there's 2 types. There's type 1 and type 2. Type 1 is typically seen in children, and it results in typically from an insulin deficiency. There's something wrong with the pancreas, and it cannot secrete insulin like it should. Type 2 diabetes is typically seen more often in adults, and it's the result of insulin insensitivity. Now, like I said, while there are several medications that are used to treat diabetes, none are going to be administered from the back table. However, the anesthesia care provider may administer glucose or insulin intraoperatively. It's a different lecture, but it's also critical when we have these diabetic patients that a lot of times they have peripheral vascular disease and peripheral neuropathy, and they're prone to not healing very well and surgical site infections. So that kind of figures into that as well. All right, we have a couple more glands to talk about before we wrap it up here. Here you are looking into the pelvic cavity. This is a scope. They're looking into the pelvic cavity, and if you take a look at the top, kind of to the right, you see that letter C. That is the uterus. And if you look down, kind of to the bottom leftish, you'll see a letter B, and that is the ovary. So the ovaries are paired glands. There should be one on the other side of the pelvic cavity as well. So there's typically two of them, and their job is to produce estrogen and progesterone. And both are critical to the development of the female sex characteristics, and they play an active role in not only the menstrual cycle, but in pregnancy and lactation as well. And they are available in several forms, which include tablets, capsules, and oil and creams. They are administered to treat things like amenorrhea, dysmenorrhea, and the side effects of menopause. As the slide indicates, these hormones are typically used as hormone replacement therapy after menopause. And estrogens are also used for palliative treatment of advanced prostate and metastatic breast cancers. And sometimes the surgeon will want, after they've completed a vaginal hysterectomy, you to put some estrogen cream on the packing, and they'll, like a Curlix roll or something like that, and they'll go ahead and pack the vagina with that post-operatively. And then lastly, the testes are paired glands as well, similar to the ovaries, and they are located in the scrotum. And they have these specialized cells called Leydig cells, and those are the ones that produce the male sex hormones, testosterone and androgen. And collectively, the male sex hormones are going to be called androgens. So these hormones, especially testosterone, are administered as replacement therapy when indicated. Testosterone can also be used to treat something called hypogonadism and some types of advanced breast cancer in females as well. Again, these hormones are typically used in the medical setting, and because of that, you won't be administering them from the sterile field. A medication called androgen danosol is sometimes used to treat diseases in females such as endometriosis and fibrocystic disease of the breast. Also, patients that are scheduled for endometrial ablation may also be placed on danosol therapy for a few weeks before surgery, and this is going to reduce the volume of the endometrial layer. Otherwise, like I mentioned, androgens have no surgical use. So that concludes our discussion regarding hormones and their use in and out of the surgical setting. I really hope that you found that this lecture contributed to your learning and growth as future surgical technologists. So I will see you next time. Take care.